Our next presentation will be given by Daniel Kennedy, who is a dental therapist from Alaska. And his is the next presentation, PowerPoint presentation in your packet. And with that, I'd like to turn it over to Daniel Kennedy.
Thank you. Good morning, everybody.
Welcome.
Thank you. My name is Daniel Bernard Kennedy. I was born and raised in Klawock, Alaska, my hometown. So I also work there for my health consortium, Southeast Alaska Regional Health Consortium. We call it SEARCH for short. And prior to going to school, the dental director asked if I wanted to go to school in New Zealand, where a lot of the people that are trained went to New Zealand for training, but then they offered it also in the United States, in Alaska, for training. So I volunteered for that, and so in 2006 is when everything started, but I was really fortunate one to be selected to go to the school. And the first year in Anchorage is the didactic portion of the schooling in Anchorage, and it was mainly, they really concentrated on pathology, biology, anatomy from the neck up, so it was really concentrated. And the University of Washington sponsored it through the medics, and they also called the Dentex program. So we were able to have the University of Washington's professors come up and teach our classes, so I was really happy to see that part. But then after that, then the second year is in Bethel, Alaska, where a majority of it is done in a clinical setting with a bunch of dental chairs. So that one was really more extensive, to the point where we had to see a lot of patients. From classes started from 8 in the morning, well, not classes, school started 8 in the morning till 6 at night, Monday through Friday in Bethel, so it was quite extensive. So that part there, I really enjoyed that part because we really got to see a lot of the people in Bethel. And Bethel is like the hub. There's like 58 small villages surrounding Bethel. And so a lot of people go to there to get a lot of dental work done. And I'm fortunate one to see a lot of that come through our dental clinic. And I've seen a lot of really hard cases come through our clinic, especially the young ones. And them in Bethel area, they don't have the opportunity to have operating room referrals. They just have to papoose board them and go ahead and dump them out and get the work done, which was really hard to see. So that's what we dealt with a lot. But in our school, we never did the papoose board. We're always able to get things done quickly. So
can I just interrupt you on behalf of the committee? Can you describe the papoose boarding process?
Okay, the papoose.
We're not familiar with that.
Well, it's a board where they put the child on and strap them in so they cannot move around. And they strap their whole body and their head because these children are screaming, you know, because of what may happen. And I think they know what's going to happen. So once they're papoosed, then they go ahead and get the dental work done as quickly as possible. So, and when these children way out in the small villages where there's hardly any dentists go there, maybe once a year, fortunately maybe twice a year. So in order to get anything done, they have to go to Bethel to get things fixed. And that's the majority of what they have to deal with in that area. But I know now that it's not as bad as it was before, because now there's 33 dental health aid therapists practicing in Alaska, and I'm one of the fortunate ones that work there. But up in interior Alaska, that's where a lot of them really work, and I'm really happy to say that one of my students is done with her preceptorship and is now working in her hometown. So it's a pretty extensive process. Once I graduated,
I think we need one of those boards, all of us, when we go into session.
I think the chairwoman should make it clear right now how she feels about dental appointments. She thinks some people have that real full. She's searching for alternative.
Say ah. Go ahead.
Okay. As I graduated, there was 4 of us that graduated in 2008, 2008, and the ceremony was in Anchorage, but this is in January. I started my preceptorship with my supervising dentist, Dr. Erickson, DDS, in Coak, Alaska. And it's usually 400 hours or 6 months of direct supervision under his care, where he looked at the patient. I did the comprehensive examination, and then when the time came, it was time to do a routine operative procedure. He would look at the tooth before I do an operative procedure, and then I prep the tooth, and then he would look at it again, and then he would okay me to go ahead and fill it, and then I would fill it, and then he would look at it again. And that process went on from January till end of June. Then after that, I became a certified dental health aid therapist in my hometown. And during that time when I was there, majority of the people in my hometown I'm related to. You know, it's amazing how small a community can be. But I didn't run into any resistance, but a little bit of hesitance. But after a while, I started seeing these patients. They all felt more comfortable with me. And it got so comfortable to the point where, let's say, a family would bring their family in and I would see the whole family. It would follow from, at one point in time in Bethel, I have to go back, I seen a grandma and I did a comprehensive examination and I got her teeth fixed. And she was so impressed that she brought her daughters in to get them all fixed, and they were so happy they brought their daughters in and their family, and it went down to 4 generations. And then when I got done by end of the year in Bethel, I seen 4 generations of the family, and they were really sad to see me go. So I know I made a difference there, but I also make a big difference in my hometown. And I often also say I put fillings of my children, my wife, brothers, sisters, aunts, uncles, everyone. So it's really fortunate that I'm working in a small town, especially my hometown. And on top of that, I also do a lot of community projects. I work for with 3 Head Starts, 3 public schools, where I started a fluoride varnish program because a fluoride varnish has been proven that it has 20 to 40% success rate of reducing cavities. So I've been doing that for quite a while, and I have noticed the reduction in cavities with these applications. On top of that, sealants. So a lot of my time is sealants and fluoride varnish. On top of that, routine operative procedures. But on top of seeing the public schools, the Head Start, I also see the seniors. I go to the senior center and I offer services to them to the point where these seniors, majority of them, I hate to say, are edentulous, and they think they don't have to go to see the dentist anymore. So there's unmet need there. So I go there and volunteer to say, I want to come to here and offer them to clean their dentures with ultrasonic equipment. And in turn, I tell them I need to see your mouth intraorally and extraorally to make sure everything's okay. I don't tell them it's oral cancer screening. That would just scare them away. So I tell them that. So now another program where I actually go to their homes and offer this. So a lot of them are, shy. They don't want to let people know that they have dentures or anything. So I go to their homes and offer this to them. And the major one that I really think I make a difference is the mothers and the mothers to be, because that's where it all starts. If you want to raise children that are cavity free, it has to start with the mom. So I get mothers in a lot quicker than the general public to get their teeth worked on. And because, I don't know if everybody knows, the cavities that are started is by bacteria and it's transmissible. So if you have cavities in your mouth, you can transmit it to your baby very easily. So I start there, and I always explain to the moms that I want to raise your child to be cavity free, and this is where it starts. I said, this is your new dental home, and I really express home because this is where a lot of the work will be done. Hopefully just routine checkups, because that's what I tell them, but right now I need to get things fixed. And so I'm able to see the children also from 0 to 3, and I'm able to work with the young ones. I'm able to actually put fillings in 1-year-old, 2-year-old, 3-year-olds, and that's quite an accomplishment, and it's very difficult, especially without getting them numb. So I practice a traumatic restorative treatment, which is to remove the majority of the cavity, put a filling in, and wait till they get older to, to do more of a comprehensive filling in there. So that's the major part I want to push, is to get to the children first before they get to the Head Start. Because in the Head Start, that's where we actually see them. They're usually 4 or 5 years old, but sometimes when I see them, if I don't get to them soon enough, they have early childhood caries, and it's so rapid that I cannot do anything, so it turns out to be an operating room referral. But in Bethel, there's no operating room referral that I know of. There may be now, but so a lot of the children go to the operating room to get things fixed. So I really have to intervene there, and it's a young program. I'm able to get to a lot of the mothers. I wish I could get to all of them, but it's hard to do that. So, and that's about all I could really talk about the dental health aid therapy program.
Thank you.
Good morning, Madam Chair, honored members of the committee. Thanks very much for inviting me to participate to speak about a subject I'm very passionate about. I'm the only member of the American Dental Association that has 20 years experience working with dental therapists, so I know more about dental therapists than any other dentist in the American Dental Association. I've been a dentist for 42 years. I've had a very interesting career. Started out as a U.S. Army dentist in Vietnam, private practice, public health, dental educator. I've trained dental assistants, dental therapists, dental students, and now I'm teaching residents. I'm teaching new dentists to become better dentists. So dental education is where I want to be. I'm presently on the faculty at the dental school in Arizona, teaching residents. So everything I tell you today is based on my 20 years of experience working with dental therapists. I trained them, I worked alongside of them, and I supervised them for 20 years. In 1974, the Saskatchewan government, Saskatchewan and Western Canada, started a children's dental program. It was a school-based program. It was made to be, we had clinics in all the elementary schools in Saskatchewan by the time the program was over. So I was one of the original 12 dentists hired in the summer of 1974 to get the program started. At that time, the children of Saskatchewan had the highest decay rate of any of the Canadian provinces. So I was one of the original 12 dentists hired to get the program started. So I went to a place called North Battleford, Saskatchewan, a very rural area, farming area, and started the program with 4 dental therapists and 4 assistants. So after 2 years of doing that, I went back to the training school and taught clinical dentistry at the dental therapy training school. The dental therapist scope of practice, they do fillings for both baby and permanent teeth. They do stainless steel crowns, which is a service that you use on a tooth where the cavity is so big that a filling won't hold in anymore, so you do a stainless steel crown which surrounds the whole tooth. They did baby tooth extractions. They did pulp treatment of baby tooth, which is called a pulpotomy. They could do space maintainers to prevent crowding. And a huge focus of the program was prevention. Our therapists always spent a lot of time with the children, the moms, the dads, the grandparents, teaching prevention and education. And that should be a huge part of any program. Obviously, there was a lot of opposition from organized dentistry. In 1974, when the program started, the private practitioners thought that the dental therapists would take patients away from them. Just the opposite happened. As soon as the dental therapists started working in the rural areas, they came across children that they couldn't help because it was beyond their scope of practice. So they referred those children to the dentist. So all of a sudden, the dentist had a new source of patients they didn't have before. Because at that time, most of the dentists in Saskatchewan were in the cities. They were not out in the rural areas. So everybody had to drive into the dentist to have care done. So now the children could be taken care of, except for those cases where the dental therapist couldn't do it because it was out of their scope. They sent them to the dentist. So the dental therapist actually became a new source of patients for the private practitioners. Once the children had their dental care completed, more parents started seeking dental care for themselves. So as I said, our school dental program had a huge education component. We always had the parents come in for the examination and treatment planning to go over with them what was wrong with the child, suggestions of how to improve their diet, how to improve the oral hygiene. And so the parents were always encouraged to come in and talk to us about their child's treatment. And so the parents also learned about diet education, and they began to raise their dental IQ. So by the time the program ended 13 years later, the dental IQ of the whole province had been raised, and more people were seeking dental services. So the private practitioners actually became busier because they had all this new input of people who now had enough education to know that there's something wrong with my tooth, I should go get it fixed. So it worked out very well as far as the private practice, and I'll get into that a little bit later. So by the time the program ended in '87, the dental health of the children of Saskatchewan had gone from the worst in Canada to the best in Canada because of the school-based program. 90% of the children signed up for the program and had their work done in the schools by dental therapists. The program was so successful that there was not the need now for the amount of dental therapists. There was a new government in power in 1987. It was a more conservative government. Money was short, so the government went to the union and said, we have to cut the program in half. We just can't afford it anymore. The union refused to cooperate, and so the government shut the whole program down in June of 1987. So that's sort of the history of the children's dental program in Saskatchewan. At the same time, there was a federal dental therapy program that's still going on. Both programs started in 1974. The federal program was focusing on the far northern parts of Canada, the Northwest Territories, similar to the communities where Daniel works. So I'll talk a little bit about that program next. So that one's still going on today. You have a picture of Saskatchewan here. There's a little thing. I lived in La Ronge, which is about halfway up. I was the only dentist that lived north of La Ronge. I was the only dentist that lived in northern Saskatchewan for 8 years. So I had a huge territory to take care of. I had a caseload of 5,500 high-needs children. I had 7 dental therapists, 8 assistants, and our clinics were in schools and mainly community health centers. So I flew 2 or 3 days a week to go work with my dental therapists. I had 2 dental therapists with me in the clinic I was in, our main clinic, which has the largest population center, which was 2,800 people, which is not a lot. And so each of our teams also traveled to satellite clinics. So I would visit with each team every 6 weeks. I'd go out and check the quality of their work. I would do the treatment plans, and I would do the procedure that they could not do. So the dental therapists have a very limited scope of practice. They only do certain dental procedures. So in their training, they do those procedures many more times than a dental student does, because the dental student has to also worry about making dentures and partials and orthodontics and root canals, things that dental therapists don't do. So they focus just on specific procedures. So I would go out, and I would also see adult emergencies. It wasn't unusual for me to see children all day, and at 6 o'clock the adults started showing up, and I worked till 6 or 9 or 10 o'clock at night seeing adult emergencies, and that was part of my job. That program's still going on today. I still stay in touch with my dental therapists that I work with. Now, as far as organized dentistry and how they accepted dental therapy, there was an unbelievable change in the attitude of organized dentistry from 1974 to 1997. So in 1995, there was a rumor that the people were so upset in the rural areas that they'd taken this dental program away from them 10 or 12 years ago, that the government was thinking maybe we should start another children's dental program. So organized dentistry said, wait a minute, how about if we let dental therapists go into private practice and work with us, and we'll work with the dental therapists. So they petitioned the legislature, and in 1997, the Saskatchewan legislature passed a bill allowing private practice dentists to employ dental therapists to provide care off-site. So the dentist could be in a city practice, hire a dental therapist, and she could go work on the reservation in a rural area and provide care to people who had never had care before. So it worked very well. The dentist made extra income because he paid the therapist a percentage of what they did. So the dentist made extra income, and those people were receiving care while the dentist stayed back in his own clinic and did the more lucrative procedures, crown and bridge and things like that. So it worked out very well. So this meant that a private dentist could hire a dental therapist to practice in a rural area away from the main office. It's called general supervision. You'll see that term used when it comes to the legislation. So this obviously increased access to rural areas because there was now dental therapists in communities that the dentist didn't want to go to. So this also increased dental incomes, and so we saw a complete change in the thinking of organized dentistry from 74 to 97. And this is a great example of how organized dentistry recognized the value of dental therapists, that they could hire another provider that was an extension of their practice, who could provide care to the underserved population that they couldn't get to and still have a successful practice themselves. So today in Saskatchewan, there's 144 dental therapists employed by private dentists. And they work in rural areas, some work in city practices and do just the children in the office, and a lot of them work on the reservations where they work, and then the dentist supervisor. So the dentist goes out, does the examinations, provides the treatment plan, and the therapists follow the treatment plan. If there's any questions, they call the dentist and they discuss it over the phone. So, and there again, it's a very safe program. The federal program at the National School of Dental Therapy, while I was an instructor for 8 years, part of my job was to travel out 2 months of the year to the Northwest Territories, Yukon, Nunavut, those places, and spend 3 or 4 days with each of the dental therapists and assess the quality of their work. That was my main function besides teaching dental therapy. So they all had an annual, formal, 2-day evaluation. I would go in there and I would pull patients at random from their charts, have the patients come in, I would do a clinical examination, check the quality of their fillings. We interviewed the school staff, we interviewed parents. It was a complete evaluation of the quality of their x-rays, quality of medical histories, the paperwork was being kept up with. And then in the federal program, there was a little bit of a difference because of where they were working. In the isolated fly-in communities where there were no roads and no way to get out and have a tooth taken out, that program involved simple extractions of adult teeth. So the provincial program just allowed them to remove baby teeth. The federal program, which again from 1974 and is still running today with 90 therapists, allowed the extraction of. And the reason for that is that the people demanded that service. And we had people literally pulling their own teeth out with pliers because they couldn't get anybody to see the care. Most of those communities, the dentist flew in once a year, would spend a week and do nothing but take out teeth, and then leave the community. So the person putting dental therapists in there was to have someone who could handle dental emergencies, treat most of those cases, and prevent all the huge transportation cost of flying out to have a tooth taken out when a dental therapist could very easily do that. So that scope of practice was a bit different for the federal dental therapists. Their scope of practice was similar to what Alaska has. Alaska also allows the simple extraction of adult teeth because of where they work. Cost effectiveness, we talked about the cost. Obviously, dental therapists cost less than dentists. The average dental therapist with salary and benefits is around $60,000. They see more patients than a visiting dentist because they're in the community every day. Most visiting dentists arrive, 8:30, 9 in the morning. They leave 3:30, 4 in the afternoon and see a limited number of patients. The advantage of having a dental therapist in the community, they can see patients all day long. They're there 5 days a week. Also, the salary dollars stay in the community. You're not paying itinerant dentists big bucks and then fly out and spend it in the city. These dollars stay in the communities. There's a great community development aspect of hiring local people to train them as dental therapists and come back to your community practice. They can successfully treat most dental emergencies, so therefore they reduce the cost to the community of spending gas money to travel out to a dentist 50 or 60 or 100 miles away. My job as a supervising dentist was much better. When I would go to the community to treat patients, the dental therapists had already pre-screened all these patients. They had taken all the necessary x-rays, updated the medical histories. So when I went in to do the procedures that were out of their scope, I was much more efficient because the dental therapists were already living in the community and they had a whole list of patients for me to see as soon as I got off the plane. So by the end of the day, I had seen all my patients. Then I could work on doing their assessment of the dental therapist. So having a dental therapist in a community also increases the efficiency of the dentist that's visiting there. Remember, all these dental therapists have a supervising dentist. Okay? They do not practice by themselves autonomously. They are a part of the dental team. The dental team is always led by a dentist. Okay, so dentists are always in the picture. So don't get the idea that these guys are, practicing in the middle of nowhere with no oversight or supervision. Continuity of care, a huge issue, as Mike will tell you from being with Pueblos, and I was the dental director in Intertribal Council of Arizona for 5 years in Arizona. I worked with all the Arizona tribes. And one thing that tribal people tell me is we're tired of the different dentists coming into our community every time that we need care. It's always a different dentist. We've got to re-explain everything to them. We want somebody locally who we trust, who speaks our language, who knows our culture. So continuity of care is a very, very important issue. So people want to receive services from the same provider every time they seek care, just like we do when we go to the same physician we go to. So dental therapists live in the community. They're part of the community life. People know them. And the dental therapists are trusted. All the surveys done in Canada and Alaska show that these dental therapists are trusted by their community because they're from the community. They know the culture, they know the language, they know how to talk to people and how to deliver care. So people prefer to receive culturally appropriate care. As far as the quality of dental therapists, you will hear people say that it's second-rate care. That is the farthest thing from the truth. There's never been a study that showed that the quality of care provided by dental therapists is any less than that provided by a dentist. Because dental therapists are limited to performing only certain clinical procedures, as I said, they have a very limited scope of practice. They focus on providing these procedures many, many times during training until they get very skilled at it. And as Daniel told you, their training is very, very concentrated. They work 8 to 6 every day, 5 days a week. There's no holidays like we have in universities. These guys work 2 years solid. So their 2 years is equivalent to 3 years of dental school because of the amount of procedures they do. They do 4 or 5 times the number of restorations a dental student does. As far as stainless steel crowns, pulpotomies, they do 10 times as much as most dental students do. Our average dental therapy student did 30 stainless steel crowns and 25 pulpotomies. The average U.S. dental student does 4. So they did a lot more of those procedures in their training, so they've become very, very good at it. As far as the quality, we did 3 studies when I was up in Canada and showed that their restorations were equal to or better than dentists. Now, Dr. David Nash, who is very well known, he's the chair of the Pediatric Dentistry Department at the University of Kentucky. He just released a report in April for the Kellogg Foundation, and he researched all the literature from all over the world on every article ever written about dental therapy. particularly the quality of dental therapy. He reviewed 1,100 articles and found that no study has ever shown that the work done by dental therapists is of lesser quality than that of a dentist. So Dr. Nash's conclusion is that dental care provided by dental therapists is technically competent, safe, and effective. There are reasons for the high quality, which I've already touched on. In their training, the dental therapists spend 4 or 5 times more time practicing doing fillings than the average dental student. The dental student has to also worry about doing orthodontics, periodontics, making dentures, root canals, stuff like that. So their work is very, very high quality because they do it so many times. Also, the dental therapists know that they are under a microscope. Their work is looked at all the time. They can have spot checks, they have annual assessments. People are always looking at their work. And so they know they better do a good job, because if they do a bad job, someone's going to find out and it's going to cause problems. So it is ingrained in their training that they are to do extra quality and to take that extra 3 or 4 minutes that it takes to make that okay restoration into a beautiful restoration. And that's ingrained in Daniel's mind and all the dental therapists that I train. And I don't train my dental students. I'm training new dentists now to become better dentists. I train them to do fillings the same way I train my dental therapists. There's no difference in the quality or the way that I train them. And as I said, quality assurance, every dental therapist undergoes a yearly formal clinical evaluation in addition to spot checks. Every time the supervising dentist comes through, they're always checking the quality of the work. And so the dental therapists know they're under a microscope, and their annual review includes the quality of the radiographs, their restorations, charting. As I said, we review everything when we go do it. So, we hear a lot of things from the dental association saying, well, these dental therapists are practicing unsupervised, no one ever watches their work. They are very, very highly supervised. The quality of their work is always assessed. Okay, on the other hand, when you're a dentist and you pass your state board and you go to practice, no one ever comes into your office and looks at the quality of your work, unless there's a seminal event such as a lawsuit or a death. That's the only time a private practitioner would have their quality of their work looked at, if there's a complaint. Otherwise, nobody looks at it. Dental therapists, on the other hand, have their work looked at all the time and actually Daniel expects to have his work looked at. That's why he does such a good job. As far as the safety of dental therapists, remember we started 2 dental programs in Canada in 1974. The federal program is still going on. There's 90 dental therapists practicing all across Canada. Since the program started in 1974, there's been hundreds of thousands of procedures done by dental therapists. Local anesthesia, extractions, fillings, injections. There's never been a complaint filed against a dental therapist, according to the federal government. I just checked with Dr. Huffman last week. There's never been a complaint filed against a dental therapist complaining about the quality of their work. That's an unbelievable track record of safety and competency. In Saskatchewan, the dental therapists that practice with private practitioners, they have to buy their own liability insurance as part of their license fee. And in Saskatchewan, same thing. I just checked with them, the insurer last week. There's never been a complaint filed against a dental therapist in Saskatchewan about the poor quality of work. Okay, so if anyone tells you their work's poor quality, that is baloney. It's based on nothing. So dental therapists have an excellent safety record treating both adults and children. So in my opinion, obviously dental therapists are a viable option for providing basic, high-quality dental services to underserved communities. I have seen over 20 years of work in Canada, rural areas of Canada, fly-in communities, that these dental therapists have a positive impact on the communities. Not only the work they do in the prevention of toothaches and handling dental emergencies to prevent people from flying out to see a private practitioner, it's what they do in the community to educate the community, to raise the dental IQ of the whole community. People become more aware of what they eat, about breastfeeding as opposed to baby bottle feeding. Don't put your Cokes in the bottles. I mean, and they're in the community all the time. They go to the store, people are asking them questions, they're in the community, and they're a huge resource of dental education information. So that's a huge, huge issue. They've been proven to provide safe, high-quality care efficiently and effectively in a culturally appropriate manner. As I said, if someone tells you dental therapists do poor quality work, you just ask them, please show me the study that proves that. There will not be a study that shows that. So in my opinion, the Alaska Dental Therapy Program is a model that New Mexico should look at. Like I said, the way the program works, the local community decides which student to send away for training. So it's a highly skilled student that people respect in the community. That's the person that they want providing their dental care. So they go away for 2 years of training, then come back to the community to be the dental therapist. As in Daniel's program, they have a 400-hour preceptorship. So even after they graduate from the dental therapy program, they have to spend 400 hours working alongside their supervising dentist. And after 400 hours or 6 months, the dentist signs off saying that they can work independently, which means they can then work in an off-site location. So there's a process that they are checked every step of the way before they go to the clinic 50 miles down the road and practice without the dentist. If there's ever a question, because of the technology you guys are going to have in the clinics, if there's a question, the dental therapist has an intraoral camera. The dentist 50 miles away can actually look in the mouth with the dental therapist, look at the x-rays, and make clinical decisions if there's a question. So thank you very much for your time. I'm sorry I went so long, but I get so excited about this because I've seen it work in so many communities, and I hope you make the right decision. Thank you very much.